Hi, everyone. My name's Dr. Bruce Moore. I'm a pediatric optometrist at the New England College of Optometry in Boston in the United States. And welcome. Topic of my talk today is a practical and evidence-based approach to vision screening of children. First, I'd like to acknowledge past and continuing support from a variety of grants and organizations and entities. I've been founding member of the Vision and Preschoolers Study funded by the National Eye Institute in the US for now 30 years. We've been engaged in trying to provide a scientific foundation for vision screening of preschool-aged children. And in later years, we went on and looked more closely at the relationship between vision problems in preschool-aged children, 3 to 5 years of age, and learning problems, and that's something I'll be talking about at length. I'd also like to acknowledge that I have been a faculty member of the New England College of Optometry for the last 25 years. I'm currently a professor emeritus, partially retired. I've been a founding member of the National Center for Children's Vision and Eye Health, part of Prevent Blindness America, originally funded 15 years ago by the United States Department of Health and Human Services, federal government. We were given the responsibility through a multidisciplinary group of pediatric ophthalmologists and optometrists and pediatricians and nurses, educators, epidemiologists, public health people, etc., to come up with a systematic approach to vision screening for children across the United States. We've been working on that for 15 years. We've published a variety of content over the years. And right now, over the next 3 to 6 months, we'll be publishing 3 papers that look at, in great depth, appropriate screening methodologies for 3 groups of children. First one, birth to 3 years of age. The second, preschool-age kids, 3 to 5 years of age. And the third, school-age children. A lot of what I'm going to talk about today has been developed through that group and represents, to some degree, those collective efforts. And that will be provided in great detail as those papers become published in the next several months. I've also been doing some work for Orbis. In Mongolia specifically, we have been implementing this vision screening program in large part across the country, both as part of a public service project through the Ministry of Health and the Ministry of Education. And we're also doing a more formalized research project to provide in-depth data about the effectiveness of this screening program in both urban and very rural areas of the country of Mongolia. So thank you for all of that. And finally, I want to give special thanks to my colleagues at Children's Vision Massachusetts, an organization that has been working to put into effect pediatric vision care programs throughout the Commonwealth of Massachusetts, which is one of the states where Boston is located in the northeast part of the United States. And I especially want to acknowledge my very close collaborator, Paulette Tattersall, who much of this work has been done in collaboration with. So thank you. So let's start off by asking a question of, ideally, providing vision care to all children at an early age would be the ideal. The problem, however, is that nowhere on this planet is it possible to provide eye examinations for every single child, periodically or even a one-off. So the only way to provide care to children on a universal basis, at least in concept, is to come up with an effective and efficient system of vision screening, which can detect children at increased risk of having important vision problems that can have an adverse effect upon their lives, on their education, frankly, on their ability to see, and then funnel those children into a care system. The difficulty is that, again, nowhere on the planet, including in Boston, a city where we have within a 30-mile radius 4 medical school ophthalmology training programs and 2 large optometry training programs, producing a large number of new practitioners every year in a relatively small state and area. Even in the Boston area, we do not have the capability of providing care to every child. Therefore, we need to establish a system of screening. So what do we typically screen for when we're thinking about vision screening of children? Well, the number one issue historically has been looking to detect amblyopia and amblyogenic risk factors, which typically are significant refractive error and strabismus. So we established screening programs to try to identify those children. But the most effective screening programs don't only look at the worst case scenario, which is amblyopia and strabismus in young children, but also more broadly, refractive errors that can, as I said, have complications for a child's education, for a child's future. So we look at amblyogenic risk factors, we look at refractive errors, and all of this has been really put an exclamation point on in the last 10 or 20 years, where we have this myopia epidemic that we're all acutely aware of. As we know, myopia has exploded both in prevalence and in magnitude, particularly in Asia, but really everywhere around the world. And what we now know, in part through a massive document that was published a couple of months ago by the National Academies of Science, Engineering, and Medicine in the United States, the NASEM report on myopia, 400-page report that looked at every single aspect of myopia in terms of the pathogenesis and the mitigations and what we do for it nowadays. And what we know from that is that the earlier we detect the presence of myopia, the earlier we begin effective means of mitigation, the form of optical correction or pharmacologic intervention with atropine or other drugs, the more effective those means are likely to be. So we now have really important reasons for detecting vision problems at early ages in children, and then periodically thereafter to, again, identify kids that are developing vision problems at later ages. And finally, this critical element that I'll come back to a number of times in my discussion, and that is the relationship between vision problems and learning problems. The Vision in Preschoolers study in its later phases looked very closely at this issue of how refractive error, moderate degrees of hyperopia in particular, can have really significant effect upon the acquisition of pre-literacy and literacy skills in children as young as 4 and 5 years of age. And we know that children that have significant impediments to seeing clearly and using their eyes in a very efficient manner are the children that are most likely, in many cases, to have problems acquiring the full benefit of their education. So vision and learning is a critical element and one that we need to be mindful of. So the rationale for modernization of vision screening is based upon a lot of things. Historically, vision screening was almost entirely based upon distance visual acuity. In the United States, there were systems of vision screening that were employed in school settings in many states, beginning in the late 1900s. Those systems all were based upon distance visual acuity only. That has continued until research in the last 20 or 30 years, some of which is provided by the Vision in Preschoolers study, showed that that is not necessarily effective. Systems of vision screening that are being developed even today, an example being the World Health Organization came out with vision screening guidelines a little less than a year ago, which employed for children distance visual acuity only. They did not include near visual acuity testing in individuals until pre-presbyopia, until adults. So there's a growing evidence basis that we need to do more. There have been dramatic improvements in the technical design of the test. We have much more effective means of visual acuity testing at both distance and near today than we did before. We'll go into that in some detail. And we've also been able to improve the testability and the sensitivity of these procedures to do vision screening, especially in younger children. It was always difficult, it still is difficult, to do visual acuity testing in 3-year-olds. But if we use the right test, designed in the right way, with modifications based upon the abilities of children in that age, we can improve testability to very high levels. In general, we need to make screening easier, faster, and better for the people doing the screening, whoever that might be, whether it's eye care professionals or educators or nurses or lay people, and also obviously for the children. We need to do a better job than what we did before. Too many of the vision screening techniques that were employed in the past either were not particularly effective, or in some cases were very complex, had many, many different procedures that were included in it, and in some cases required eye care professionals, optometrists and ophthalmologists, to be able to do the screening procedures. That's not an efficient and effective system that can be disseminated broadly in countries around the world. We also today have the ability of better balancing under referrals and over referrals based upon the cutoffs that we use. For example, if we had a very high visual acuity cutoff of 2060, 2070, then we would be missing many, many children with visual acuity poorer than that. On the other hand, if we had an acuity level of 2025, we would be over-referring a lot of kids and clogging up the system with children with only marginal, at best, deficits in vision that would make it more difficult for children with more complicated, more immediate vision problems, having increased difficulty with access to care. So we've made the test easier, faster, and better, and we've modified the cutoffs to try to balance sensitivity and specificity as much as possible. Now, the epidemiology of vision problems and the effect they have on children varies quite dramatically with age. Obviously, in high school kids, 15-year-old kids, it's all about myopia. We know myopia is the big problem, and we recognize that techniques to detect presence of myopia can frankly be as simple as distance visual acuity. But in younger children, 3-year-olds, there's very little, if any, myopia. That's not the reason we're screening 3-year-old children. We're looking for amblyopia and amblyogenic risk factors at that point. So the conditions are different, and that means the tests need to be different. There also is quite obviously big differences in the cognitive ability of children. A 3-year-old is not able to do the same complex tasks as an older child. So what that translates to is that if we create multiple age groupings that can better target specific vision problems that are important at each age cohort, we can make those tests more effective. We can increase the efficiency and the effectiveness in detecting the important vision problems of children at those ages than if we had the same procedure for children of all ages. Obviously, doing a whole chart of distance visual acuity targets to a 3-year-old child is not going to work very well. So I've already said that distance visual acuity alone is inconsistent in its ability to detect certain vision problems, and that is in particular moderate to high degrees of hyperopia and astigmatism. So on a transient basis, a child may easily be able to overcome with accommodative input hyperopia of even moderate to high degrees if looking at a distance visual acuity chart with only a small number of optotypes on it. So VIP study and other research has determined that in order to properly detect the presence of hyperopia of large degrees and astigmatism to varying degrees, you need to do more. near visual acuity is one of the ways that we can do that. But if you also think about strabismus, child, for example, with a large angle exotropia might have excellent vision in each eye. So if all you're doing is distance visual acuity testing monocularly, you're not going to detect the presence of that. So you need to do a test that has the ability of requiring a child to effectively and efficiently use both eyes at the same time. Test of binocularity and particularly stereopsis meet that requirement. So there is a necessity to probably use a combination of distance and near visual acuity and a binocularity procedure. In this case, we're going to be using a stereopsis test. What we're talking about here, the system that I'm going to be presenting, is a consensus-driven model of vision screening with a very strong evidence basis to support it that has been developed over the last 30 years in the United States and around the world. It is a procedure that, as I mentioned earlier, was really developed by a lot of research and a lot of consensus opinion by the National Center for Children's Vision and Eye Health. And the major papers that will be coming out will be providing great detail about that. But what I'm going to be presenting here in a model that I'm calling the Massachusetts-based vision screening model will be applicable to children around the world. Now, this particular set of procedures was developed by a group of us from Children's Vision Massachusetts in collaboration with the Massachusetts Department of Public Health, and has been implemented now for several years across Massachusetts, both in educational settings, school settings for children 3 to 18 years of age, and in medical home settings, pediatrician offices and clinics that are utilizing a very similar system. This follows many of the precepts of the American Academy of Pediatrics, guidelines by the American Academy of Pediatric Ophthalmology and Strabismus, the American Academy of Optometry, and the American Academy of Pediatrics, and a variety of other organizations have all looked at these consensus approaches and agreed that this is the way the system should be modeled. Now, again, modifications can be made based upon the needs of specific communities, based upon languages and culture and other issues like that, but this is a model. First, want to mention a few things in particular about visual acuity methods that have been widely used in the past that have now been discontinued in Massachusetts and are not recommended for use in the US and elsewhere. The top of the page, you can see tumbling E chart. Now, I know many of you around the world routinely use tumbling E charts, and long history of usage can be very effective, but there is a real problem with it in children, and particularly in younger children, children under the age of 7 in particular, but many cases even older children. And that is, as a developmental attribute, laterality, the determination of left or right, is not complete in many children until a little bit later on. So if you present a tumbling E chart to a 3 or 4-year-old child and ask them to do this or this, you're going to run into a problem because many of those children are not able as effectively to do left and right as they are up and down. So there's been a lot of research done on that. It's been shown that this issue of laterality is a real complication. So in the US, this chart is not widely used and not recommended. The Landolt-C on the bottom left is really the basis of a lot of visual acuity testing design over the last 30 or 40 or 50 years. There's a very strong scientific basis for the uses of that. However, on a practical basis, it's a difficult test for children to do. And we have not used that test in the United States. So tumbling E and the Landolt-C, which are widely used and approved and have good scientific basis in older individuals, are not useful in our view in children. There are any number of picture charts represented on the bottom of this page that have been used for a very long period of time. The second from the left on this page is the Allen cards, widely used, devised by a pediatric ophthalmologist, Henry Allen, probably 40, 50 years ago. The difficulty with that is that you could simply look at those optotypes and you could tell that there are differences in the shapes that go way down towards threshold, and you can still tell even below threshold different shapes preferentially. The chart next to it with that horse on top, or the one next to that with the sailboat on top, are sort of particularly egregious examples of badly designed charts. You look at the sailboat, for example, and you look at the O or the plus just below that. Even way below threshold, it's easy to tell the difference. Same with the horse on top and the dinosaur just below that, the giraffe. Not effective. On the far right, you have an old style Snellen chart. The problem with that is not necessarily the letters. The problem with that is that it is not a log mark configuration. I'm not going to go into all of that. Most of you, I'm sure, are very familiar with the concept of logmar visual acuity. So it is imperative, we believe, that charts that are used be able to conform to logmar design. So there are many types of visual acuity charts that have been in use for a long time that we believe should not continue to be used. What is approved? I'll go through these one by one. On the top left, it's called the eye check. That test is done at 1.5 meters. This is based upon research from the VIP study that showed that in 3- and 4-year-old children, closer distances beyond the 3 meters, or closer than the 3 meters that is typical for use in children, enhances the testability quite dramatically. Another design element is the use of a single surrounded Lee symbol optotype. Now, we recognize that if you don't use an entire chart as on the bottom, then you're not getting the full benefit of the crowding effect. We know that if you put various crowding bars or details surrounding either a single optotype or as on the right side on the top, the side line, where you have 5 optotypes next to each other with a crowding box surrounding it, you do get improved elements of crowding, although you do not reach full crowding benefit. So the eye check 1.5 meter chart is designed for use in the youngest children where testability is a major issue. Getting the child to actually be able to do the test is really difficult. So you need to provide some design elements that enhance that, going to the single crowded optotype, going to a closer distance, and using the Lee symbols is a way of enhancing testability. Studies have shown that you can get probably over 95% of most 3-year-old children to be able to do effective visual screening with a design of that sort. Notice also there is a cord that is held by the child to their eye about over here. The cord extended out to where the screener is holding the cards and presenting it to the child. That maintains the distance. Maintaining the careful distance is absolutely essential. Now, going to 1.5 meters has the deficit of missing some children with low degrees of myopia. However, in the youngest children, low degrees of myopia are simply not an important problem to detect. So we're willing to forego that enhanced detection of low degrees of myopia to improve testability. Now, a couple of comments about the Lee symbols. As many of you know, the Lee symbols were designed by the pediatric ophthalmologist from Finland, Leah Hyvarinen. She designed that so that it would have universality in being able to be utilized by children around the world. And she and many others have shown that it is relatively culturally neutral, that children can use a matching paradigm to not necessarily have to name those symbols, but can simply match it with a lap card, as shown on the top right on the sight line. Child can hold that card with the 4 symbols and can point to the one that looks the same as being presented by the screener. The Leah symbols have one really important benefit over all others, and that is they have equal blur. Dr. Hyvarinen titrated the actual size and dimensions of those symbols so that at threshold and below threshold, those symbols all have equal blur. So unlike the kindergarten chart with the sailboat or the horse on top on the previous slide, where it's relatively easy to make a determination based upon differences in shape and contour, you can't do that with the Leah symbols. So there are some really major advantages of that. In the US, we also use the letters H, O, T, and V, but in the designs that we've utilized in this series, we're not using H, O, T, V. We're using Leah symbols instead. So again, eye check on the top left, 1.5 meters, sight line on the top right, 3 meters, standard testing distance, and again uses 5 Leah symbols with a crowding box around it, can be used as a matching. There's a cord to maintain distance. The charts below that are for the older individuals. Sloan letters, the 10 letters that were designed that have particular characteristics, presented in a logmar fashion is probably the best approach to visual acuity testing. We can also use the Leah symbols on a whole chart. But an important point, and I'm going to make this again, is that we do not do threshold visual acuity testing. In other words, we do not start at the top and go line by line down to the bottom until a child misses at least 3 of those and ends it at that point. We go to a critical line. So we have determined a specific line the child must pass. We go directly to that line. I'll go into that in a moment. Child needs to get 4 out of 5 correct on that in order to pass for the right eye, then 4 out of correct on the left eye. And that could be done either with the Sloan letters or it could be done with the Leah symbols. For near visual acuity that we use ages 3 years of age up to 3rd grade, roughly age 8 years. We also include near visual acuity. Near visual acuity, again, because we're doing it only in the younger children, are the Leah symbols. And again, we use a critical line. With near visual acuity, we do OU only, both eyes together, in order to enhance the speed and efficiency. And again, there is a cord attached to that to maintain that critical distance. The approved stereo test is a simplified version of the PASS test, Pediatric Assessment of Stereo Vision, sometimes also called a stereo smile test. This was devised by one of my colleagues in the VIP study, Elise Siener, and we are using 120 seconds of arc as the test plate. This test has 3 cards. One is a blank. One is a demo card that has a picture of a smile face printed on it, as you can see here. The 3rd plate is the test plate that has a random dot stereogram at 120 seconds of arc. The VIP study showed that in 4- and 5-year-old children, those children that were unable to get this plate at 120 seconds of arc had a deficit in terms of amblyopia or near visual acuity. So we feel it is important to include a stereo test to be able to detect presence of strabismus and amblyopia. There are variations of other stereo tests that could potentially in other countries be used in lieu of this. I'm not going to go into that, but keep in mind that all of the tests that I've shown on the last couple of slides can all be substituted for other tests of equal scientific value in other countries for a variety of reasons. Now I'm going to show 3 charts that go into specific detail about the Massachusetts Vision Screening Guidelines. And as I said, this has now been employed in the schools and in the pediatrician offices across Massachusetts. This system has been in place for several years. It's been used relatively efficiently and effectively without a whole lot of difficulty. The uptake on it has been quite good. We have not had very many complications or problems as a result of it. So we're quite confident that this is a system that can be used on a wide public health basis. So there are 3 charts here that I'm going to be showing. The first one on this side, on this screen rather, shows the system for the pre-K, children 3 to 5 years of age. Below that for kindergarten children. And it includes the details. And for the youngest children, we can use either the eye check or the sight line. Again, either the 1.5 meters or the 3-meter test using crowded Leah symbols in a variety of ways. We use a distance visual acuity. We use the near visual acuity. We do not, however, for the 3 to 5-year-olds, use the stereo test. And the reason we do not use the stereo test in these young children is that the testability in children 3 and 4 years of age is reduced in terms of being able to actually accomplish effective testing with the stereo pass 1 Ohio version. And that means that we would get too many over referrals. So at this point in time, we are not using a stereo test in the youngest children. There is an alternative to using distance visual acuity, and that is we can use instrument-based screening in these 3 to 5-year-old children, actually 3 to 6-year-old children, including the kindergarten kids on the table below. Instrument-based screening using photo screeners like the Spot or the Plus Optics is widely used in the United States and around the world today. Very fast, very efficient. However, there are some issues. And those issues are that photo screeners have a technical problem with the ability of detecting accurately the presence of moderate to high degrees of hyperopia. In studies that we and others have done, we have shown that the system tends to break down with children having over 3.5 diopters of hyperopia. It misses many of these children and has an inability to provide an accurate measure. So that provides concern on my part. Nonetheless, because of the improved testability in some of these 3-year-old younger children, it is widely used and it is approved by the American Academy of Pediatrics. So in our guidelines, we do allow for the use of that. However, because of its difficulty with detecting hyperopia, we do want near visual acuity to be used in addition to the photo screener. So whether you use distance VA with a 1.5 meter or 3-meter test of Leah symbols, or you use a photo screener, you need to do the near visual acuity in addition. For the kindergarten children, we add the stereo test because at that age, the testability is high enough. And again, for visual acuity, you need 4 out of 5 correct. On the sight line, on the eye check, the more simplified version, 3 out of 4 is required on each eye. On this next table here, we have grades 1 through 3 on top, grades 4 through 5 on the bottom. For grades 1 through 3, we continue the requirement of the distance and near visual acuity along with the stereo. We are still interested in detecting amblyopia at this age. This is really when myopia begins kicking in, and we know in some Asian countries, myopia starts kicking in earlier than it does typically in Western countries. Again, the reasons why, still up for discussion. but we include all three of those tests. Once we get to the 4-year-old children, we're really now concerned with myopia really alone. And we now use only the distance visual acuity procedures for children grades 4 on up through high school. And this table here shows grades 6 through 8 and 9 through 12. And again, we do that. Now, the frequency of the test, in the earlier grades, we do it every year. So between preschool and 3rd grade, we do screening every year. What's important about that is that even if we miss child with important vision problems at an earlier age, hopefully we'll capture that child the next year. So doing it each year, we believe, is important in the younger grades. When we get to the older grades and we're talking about myopia and increasing levels of myopia, these children who already have been detected as having myopia are already in the vision care system, hopefully. So we'll leave it up to the vision care system to be the primary means of follow-up care, but we will repeat the screening once in middle school and once in high school in Massachusetts. We've reduced the frequency so that we allow the people doing the screening in the schools in Massachusetts. We have a system of school nurses that are present in all schools. We have the burden of effort on those school nurses to do the screening in the younger children where it's more critical to pick up amblyopia and amblyogenic risk factors early. And when we get to the older children, we drop down the frequency. Now, I've talked at some length about the idea of using critical line as opposed to threshold. This is perhaps a point of contention among some. Now, very often, historically, screening systems use threshold visual acuity. And there isn't much question that that is a more effective way of measuring visual acuity, no question. However, it takes much longer to do. And when we're trying to think about screening an entire school full of children, we need to find deficiencies where we can. So this is one of the accommodations that we've made of going to a critical line. And that concept of critical line is really very widely used and has been for a long time in screening systems in the United States, perhaps less so internationally. For the youngest children, our critical line is 2050. Children a bit older, 4 and 5-year-olds, it is 2040, and for the older children, it's 2032. Now, again, you may argue, why 2032? Aren't we interested in picking up kids with lower levels of visual acuity than that, more reduced levels of visual acuity? Sure, but again, we're looking at overall efficiency. Child that has 2032 is still capable of performing quite well at distance, perhaps not perfectly. And if we look at guidelines for visual acuity requirements for people doing examinations for eligibility for driver's licenses and maintaining driver's licenses, pretty universally 2040 is the level. So we feel that 2032 is a reasonable compromise. Again, we are extremely mindful of not overloading a scarce availability of access to care of individuals needing eye care to get to an eye doctor who will be able to examine a child. We don't want to overload the system. So we've made some accommodations. For all but the eye check, again, for the very youngest of the children, 4 out of 5 symbols correct at that passing line. For both the right eye and the left eye is required. At distance, for near, it's OU, 4 out of 5 correct on that near chart. Child does not get 4 out of 5 correct, it is a refer. Let me talk a bit more about instrument screening. There's no question that this is the technology that is being embraced everywhere. Everyone likes the idea of the speed, of the fact that it does not require a whole lot of experience in terms of doing The test itself, pressing the button on the spot of the plus optics, as long as you have the right environment, reduced illumination, you have a child the right distance, you don't have a lot of noise going on in the room and a lot of movement going on in the room, you can do a lot of children in a very short period of time using instrument-based screening. Instrument-based screening has been approved by the American Academy of Pediatrics up until 6 years of age. And it is a reasonable approach, particularly for the younger children. The concern that many of us have, as I pointed out earlier, is that there are technical limitations in the ability of these technologies to be able to accurately measure moderate degrees of hyperopia over about 3.5 diopters. It misses many of those, and that is probably almost the single most important group of younger children you want to detect the presence of. So until the technology improves, until the companies improve their technology or their hardware or software, we're kind of stuck with this. It is useful, of course, in young children who are shy, non-communicative. You can get a measure as long as a child will look at the instrument. But again, there are concerns about it, and I think until the technology gets better, many of us are not completely comfortable with it. Now, this is something I think that is very, very important. We recognize that screening for any health condition is intended to identify individuals at increased risk of having that disorder, whatever that disorder might be. In terms of vision screening, a child with neurodevelopmental delays, an example would be Down syndrome or cerebral palsy or hearing impairment or autism, many other conditions. These children already have conditions that put them at high risk. An example would be Down syndrome or cerebral palsy. The majority, probably the vast majority of those children have important vision problems. So you already know they're in a high-risk population. Those children need a comprehensive eye examination. So it's fine for social purposes to screen that child along with their classmates. So if you bring a whole classroom of kids down to an auditorium and you screen every child, don't leave out the child with cerebral palsy or any other form of neurodevelopmental delay. Screen that child as well. You don't want to separate them from the other kids. But that child needs a comprehensive examination because of their high risk of having vision problems. The definition of neurodevelopmental delay is very much a moving target. So when we first came up with this requirement 20 years ago, there were definitions by pediatricians of who that included. But that's changed over time as the understanding of these conditions have changed. So we'll leave it up to the pediatricians and others to decide who has a neurodevelopmental delay. And in other environments, in other countries, the definitions may be different than in the US. But be clear about this. Any child that is already at high risk for coexisting conditions, whatever those might be, physical, emotional, educational, those kids need an eye examination, not a screening. So who should automatically be referred? Well, again, these children with neurodevelopmental delays, but any recognizable eye abnormality like strabismus rhotosis. So if the screener sees a child with a bad eye, however you want to define a bad eye that's visible, even to a lay person, child obviously needs an examination, not a screening. Any child with a systemic disease that has known ocular complications, examples, diabetes, juvenile rheumatoid arthritis, where there are absolutely significantly elevated risk of all kinds of other eye involvement, those kids need to be part of the vision care system and to be under the care of people on a continuing basis. Individual that has a medication that's known to cause eye disorders or complications like scopolamine, for example. A child born to a mother who, at the time of pregnancy or delivery, was using or abusing tobacco or illicit drugs or alcohol, any of those kinds of conditions, needs to have a comprehensive examination. We now know the link between smoking, for example, and increased risk of strabismus and amblyopia is real. These kids need to be examined. Obviously, a child who falls into the category of retinopathy of prematurity risk, premature birth under 32 weeks, low birth weight, etc., obviously needs to be under the care. In addition, a child with a first-degree relative with strabismus or amblyopia or simply very high refractive error should also have at least an examination initially, and then if nothing shows up, then just periodically thereafter. Any child who failed vision screening or any kind of a child that has any kind of observable eye abnormalities needs to be followed up and examined. Recommended, if a parent or a caregiver or a teacher has concerns about a particular child, even if that child passes a screening, the child should have an examination. I can't tell you how many times we've gone in and done screenings in schools. We ask a teacher when they bring the child down to the auditorium, they bring the class down to the auditorium, you have any particular concerns about any one of your kids in your class? You have any young child who won't sit still at circle time, who runs all over the place, who has difficulty holding objects at a reading distance? Regardless of whether that child passes the screening or not, that child should have an examination. Any child not reaching developmental milestones in an appropriate fashion should have an examination. In the US, we have an elaborate system of early intervention. So pediatricians make note of a child having any kind of developmental abnormalities of any kind at all, can refer that child into a system of providing remediation and diagnostic workups. Those children should have comprehensive examination. A child that has significant difficulty learning to read or educationally, a child in special education, child where parents have concerns about a child's education, should obviously find out if a child's got a vision problem or not. If they do, that may be the entire cause of the difficulty of learning. So those kids need to be screened and then examined. Child that's difficult to screen, who just doesn't pay attention or is untestable, or a child that you can't get a result on a photo screener, needs to have a comprehensive examination. So I'm going to stop here for a moment and we're going to present some questions. Let me read the first question to you. Important considerations in determining the most appropriate approaches to vision screening must include which of the following? And the answer is all of the above. You think about the epidemiology, you think about the cognitive ability of the child, and you also need to have efficiency and effectiveness in the technique. So all of the above. Very good. Next question, which of the following is not an important issue when devising a system of vision screening for children? And correct answer is employing the latest technology. We don't care about the technology so much. As I pointed out, the photo screeners are the latest technology, and frankly, they're not as effective as the manufacturers would like us to think. Next question, which of the following is the most effective technique of vision screening to detect the presence of strabismus? And the correct answer is stereopsis. Out of all those, stereopsis. Could argue all of the above, but I think stereopsis was the one I was looking for. Remember, I gave the example of exotropia. You can have perfectly good vision in each eye, and yet no stereopsis. Distance and near acuity will not necessarily tell you that. Which of the following is not true? A little bit more complicated. Okay, and the correct answer is the photo screeners are not so effective at detecting the presence of significant hyperopia. I should point out that screening is never 100% sensitive and specific. screening for any condition at all. You'll never get perfection. And children with neurodevelopmental delays should absolutely have comprehensive examinations. And using a critical line for visual acuity is effective and efficient. Perhaps it's not quite as accurate as threshold, but in the context of screening, it is effective. All right, so this chart here, signs of possible vision problems in children, is presented by Prevent Blindness America. This is, I think, a very useful chart, and Prevent Blindness has lots and lots and lots of downloadable educational content available both in English and in Spanish, and anyone is welcome to translate any of this into their own languages if they like. There's a huge amount of content available that I think all of you will find very useful in systems within your own countries. So by all means, take a look at the page there, preventblindness.org, and you will find lots of stuff that I think will be quite useful for all of you. There's a bunch of additional slides here that I'm not going to have time to go through, but I've included them to help any of you in terms of actually establishing a system of vision screening. Whether you employ the recommendations of what I presented here today in great detail, what I'm going to show you in the rest of these slides is a lot of useful information on the practical aspects of establishing systems of vision screening. So I'll just really quickly go through it, how to set up a screening room, how important distance is, screening steps, doing visual acuity testing, all the details of that. And a lot of this was put together by my colleague Paulette Tattersall. I want to give enormous credit to for putting all of this together. Lots of information here about acuity, about stereo testing. And again, these on this slide are all sources of information that anyone can download, can look at, can use to help them come up with systems. And finally, some things to remember. Vision disorders are the most prevalent disabling condition of childhood, put together by the Centers for Disease Control in the US. No child is too young to have or develop a vision problem. Most childhood vision disorders are treatable. Amblyopia in concept is detectable at an early age, and in most individuals, treatable in many if you capture it early enough. Same is true for myopia mitigation. You get it early, you can be more effective than if you capture it late. Vision screening will never detect all problems. If in doubt, refer to somebody who knows what they're doing. And glasses are a treatment and should not be considered optional. Finally, I want to thank everyone for their attention, and we have some time for questions. All right, first question from Grace. Dr. Moore, I want to ask if students can be trained to carry out vision screening in schools and communities. And the answer to that is absolutely yes. It's my view that schools are probably the best environment to do vision screening at. Those extra slides that I just mentioned and went through super quickly were there to help you provide information about how to go about actually establishing a system. Okay, next question from Monica from Columbia. Is the Lang 2 stereo test acceptable for stereopsis? And the answer is yes. The example I gave of the Pass 1 Ohio test, some technical reasons why we use that in Massachusetts. There are many other stereo tests that are useful. The important point in that is that research has shown that a child that is able to obtain at least 100 seconds of arc on a stereo test is unlikely to have amblyopia or strabismus. It does not mean they will not have amblyopia or strabismus, but it's highly unlikely that they will. So you can utilize other tests that are available to you in the environments that you're in, and feel free to substitute. And the same is true for the visual acuity charts that I showed. Really, they're just examples of what we find through good science is useful and acceptable, but you can use alternatives. I think in particular about languages like Arabic or Hebrew or Mandarin or Thai, or take your pick of any other language that does not use Roman letters. Visual acuity characteristics of those languages are something that has really not been studied very thoroughly in many cases. But obviously for children in those countries, you'll need to make accommodations. So there are options available. All right, next question. Amblyopia is not well treated at age of 8. Well, as we know, amblyopia in concept can be effectively treated even at much later ages. The new techniques that are being developed, these binocular techniques, appear to have much more efficacy of their ability to treat at later ages. But from a practical perspective, you really want to find amblyopia and amblyogenic risk factors at early ages, because your compliance is invariably going to be better at younger ages than it is at older ages. And everything about treating amblyopia is about compliance. Okay, in the UK, we have a 2-tiered system: vision only, no strabismus or photo screen. Scotland has a different system. Yes, Scotland does have a different system than England. Are either of these public health measures effectively equal? Well, I mean, this is something I think that you're going to have to figure out how effective your systems are. So ideally, you need to do large population-based studies of different methods of vision screening to find out what works within your systems of healthcare, within your cultures, within your systems. What I presented is applicable particularly in the United States, other countries, different systems. The idea of screening periodically and front-loading screening particularly heavily on a yearly basis in the younger ages, I think is absolutely essential. I think at older ages where you're looking for myopia, and we know, or at least we think we know, that kids who are myopic tend to be kids who do better in school. Kids with amblyopia and high refractive errors at earlier ages are more likely to not do as well in school. So it seems to me, given the connection we now understand between vision and learning, front load your systems to provide the most aggressive efforts at detecting vision problems in the younger kids. But again, it depends upon the level of resources, and many of the Western countries, US and the UK, you've got a lot more resources available than in countries in, say, Africa, sub-Saharan Africa. So these are things that individually need to be considered. Okay, Dr. Moore, with an already overloaded clinical staffing situation, how have you managed to go around the extra man hours required for comprehensive regular screening program? Secondly, any comments on applicability in resource-limited settings? So, I do believe that vision screening can and should be done in school settings. What we're doing in Mongolia, a country of very, very sparse population density, a massive country with relatively sparse resources, particularly out in the countryside, we are using school systems and teachers to do screening. We are pretty convinced that we can teach teachers to do adequate screening in a very methodical way. One of the great advantages of teachers doing screening is that I believe that teachers are in a better position to work effectively with their students. They know those kids, they know the communities, The communities trust those teachers. The children work well with those teachers. Frankly, the children and the parents work better with the teachers than they frequently do with the healthcare system. And I think that you train teachers to do the right test done in the right way. I think that is the most effective system. Teachers also are in the best position to convince the parents how important it is to get those kids to care. So those teachers are in a better position to manage the follow-up to get to an eye care professional. So I think particularly in low resource countries, the most effective way of doing universal vision screening is not initially through the healthcare system, but through the education system. Obviously, those two need to work together, and you need to establish the referral basis and the referral methodology so that kids get to care. Difficulty is that if the care is not available in a rural community, how do you get kids to go from that rural community into a more urban setting where the care might be available 20 or 50 kilometers away? That's difficult, and that is really the essence of what I think needs to be developed. Okay, so a question from Ghana. I like the fact that the charts can detect myriad vision problems during screening, but has this test chart demonstrated good sensitivity in children across various demographics? The answer is yes. So the LEA cards, the LEA visual acuity system, has been used everywhere around the world. Dr. Hyvarinen was particularly interested in ensuring that that was a culturally neutral way of assessing visual acuity in children living in rural communities in low resource countries. So I do believe that that is an effective way of going about it. Using the letters, as I pointed out, in Roman letters, in nations that don't use a Roman alphabet, Arabic for argument's sake, or Mandarin or Thai, again, LEA symbols I think have enormous efficacy, and it's something that can be done by children of all ages. What is the normal range of good stereopsis for a 4 or 5-year-old child? Well, there have been a lot of studies that have looked at the development of stereopsis. We know that stereopsis begins developing at around 6 months, 8 months of age, probably earlier than that. When does it reach adult levels? Certainly by 3, 4, 5 years of age. 100 seconds of arc is definitely within the range. Probably much, much better than that, probably down to 40 or 60 seconds of arc in 3 and 4-year-old children. The VIP study did threshold testing down to 40 seconds of arc, and we were able to do that in a high percentage. So I think you can get good stereopsis in 4 and 5-year-old children without any difficulty. Again, we've picked 100 seconds of arc, specifically the test plate of 120, because that seems to be an effective cutoff for yes or no in terms of amblyopia and strabismus. Okay, how do vision screenings address children with neurodevelopmental disorders such as autism or ADHD who may not respond well to traditional tests? Yes, absolutely. That's the problem. There is no way of doing a screening on children with autism. You can't do it. It's not effective. I think for many of us who work with kids with special needs, work with kids with autism, I've had 50 years of clinical experience. I can tell you it's hard for me in many cases to do a good examination on a child with autism. You can't do screening on these children. That's why these children must have a comprehensive eye examination. Many of these individuals, they depend to a much greater degree on their visual system for their learning, for their dealing with their environment, for their day-to-day tasks than typical children. So ensuring that they have the best vision possible to allow them to perform to the maximum level is critical. I would go as far as saying that national vision care systems should put the emphasis on these children with medical, social, educational problems over all others. These are the kids that it's most important to get to. Provide examinations for those children. Uh, in your experience, why and how can teachers be empowered as allies to optometrists to communicate the importance of screening and vision care to parents and tutors? Well, this is something that I think is really critically important. So not only optometrists or ophthalmologists, but all of us in the healthcare system need to understand how important vision is, how important healthcare is for children to reach their full potential. So we as eye doctors can't look at vision care as being separate from everything else. It's not. We need to work with the communities. We need to work with the parents. We need to work with the educational systems. We need to work with governments to get them to understand that providing vision care to children and detecting vision problems that can be complications for children obtaining all that they can and should in life and in education is something that is worth putting resources into. So it's critically important for us as eye doctors to work to educate national systems of healthcare, national systems of education of the critical impact of vision problems on learning. And only through a concerted effort of working together can we implement vision care that does provide enhancements to a child's education. So it needs to be a full-blown effort. Optometrists, ophthalmologists cannot work in isolation as they too often have. We can't simply think as eye doctors how important it is to find eye problems in children. We need to be thinking in terms of ensuring that children's vision systems are as finely tuned as possible to allow them to reach the full capabilities. Next question about color vision testing. We looked at that in the VIP study at the very beginning 30 years ago. I have a Dutan color deficiency. I can say from my own experience how it has impacted my life. And the answer is only when I took organic chemistry in university, could not see the color changes. Did it really have an impact when I failed the lab? The problem with color vision testing is that we do not have good methods of screening for color vision deficiency. To do color vision testing properly, you must have the right illumination system. I'm sure all of you remember learning about Illumin C, the right color requirements for color vision testing. How many of you actually have Illumin C in your offices? The answer is probably very few. So screening for that is simply not going to work. All right, I did not mention retinoscopy. And the reason I did not mention retinoscopy is that it's an eye doctor procedure. And I don't believe that vision screening should be done by eye doctors. Vision screening should be done by others. Eye doctors should be working to pick up the children who have already been detected or are known to have vision problems. They ought to be spending their time doing that. Screening should be done by other people. Of course, retinoscopy is the best technique for detecting refractive error, but it is not a procedure that could be done by anybody other than eye doctors. So I don't think that it's something we ought to be thinking about. What are your considerations for very young infants with high refractive error? Well, that's a whole different story. We don't have good systems of vision screening for children under the age of 3 years now, except for photo screeners. Photo screeners are probably the only way we have now. There's the other technology called Blink, devised by David Hunter, head of ophthalmology at Boston Children's Hospital. That is an amblyopia detector. It is actually a strabismus detector, and that may be the best approach. It's still, it's been commercially available, but I think the use of it is still in development. People are trying to figure out how to utilize it. Bottom line, we do not have at this point in time good methods of vision screening of younger children beyond photo screening. I wish we had better technology at some point, hopefully will. What are the considerations in doing refraction of a child under general anesthesia? Answer to that is don't do it. Reason being, I had a lot of experience in my earlier days working with kids with congenital cataracts and trying to fit contact lenses under anesthesia. What happens is anesthesia drops intraocular pressure dramatically, collapses the anterior chamber. The refractive error you find under general anesthesia has no bearing whatsoever to what is available not under anesthesia. Do not measure refractive error under general anesthesia. Can strabismus develop in older children? Yes, of course, for a whole variety of reasons. Kind of goes beyond what we've got here today available, and I'm running out of time. I think I have time for one more question. Last one being, what is the appropriate device for checking distance visual acuity and near visual acuity, stereo acuity in children age 4 years and above? Well, I did present that in my system that I presented the Massachusetts system, so it is really all there. All right, we have run out of time. I would like to thank you all for your attention. You can find me. Hopefully, my email will be available. It's brucemore49@gmail. And if you have questions, get in touch with me. What I do hope is that for some of you, we may be able to work in the future through Orbis and develop approaches to vision screening for your countries as we are doing now in Mongolia. So I will leave you with that. Again, thank you for your attention. And I hope you all have learned something useful. Most importantly, take what we've learned here today, try to think about how to utilize that within your own communities, begin discussions with other people within your eye care and healthcare systems, talk with the educators, talk with the public health people, get systems of effective vision screening that are evidence-based into play in your communities, and you will have an impact upon the visual health of the children and the future of your countries. Thank you again, and have a good day.